Basically it's a disease caused by Mycobacterium leprae. It affects the skin, it affects the nerves. The nerves are damaged in long term disease progression, and they show cutaneous lesion. The primary pathology is basically chronic granulomatous infection like that of Mycobacterium tuberculosis. So leprosy is caused by Mycobacterium leprae. It was once incurable like that of tuberculosis, but with the advent of the newer anti-leprotic drugs, it has been become entirely curable, but the deformities once incurred due to progression of the disease is not curable right now even. So what are the anti-leprotic drugs available? These include number one very important drug, Dapsone. Initially, the leprosy used to be treated only with Dapsone monotherapy. It was the first drug to be used. So, sulfone group of drugs, Dapsone. Number two is Clofazimine. Number three, anti-tubercular drugs. Some anti-tubercular drugs are also used as anti-leprotic, particularly Rifampicin. It is one of the basically drug that is used in multi-drug therapy of leprosy. So, Rifampicin and ethionamide. Some antibacterial agents are also used that include ofloxacin and moxifloxacin, clarithromycin and minocycline. So, these are the drugs which are used in patients of leprosy. Coming to the Dapsone, seeing the structure is basically a diamino diphenyl sulfone. So, this is a sulfone ring. It is the simplest, oldest, most commonly and most active member of its class. And the other members of the sulfone class has been obsolete now. Now, how does Dapsone act? Mechanism of action. Mechanism of action of Dapsone. How does sulfonamide act? এটা তো অ্যান্টিব্যাকটেরিয়াল ক্লাসে হয়েছে তোমাদের। Basically, they inhibit incorporation of PABA, para-aminobenzoic acid, in the folic acid by inhibiting the enzyme folate synthase. So, the action of Dapsone is basically similar to sulfonamides. They inhibit incorporation of para-aminobenzoic acid into the folic acid by competitively inhibiting the enzyme folate synthase. The antibacterial action of Dapsone is antagonized by PABA, and this shows that is competitive inhibition. It is leprostatic at very low concentration, and at higher concentration even it is static to other antibacterial to other bacteria also. Anti-inflammatory property has also been seen with Dapsone. Now, Dapsone is now a part of multi-drug therapy of leprosy. Well, there are two types of resistance that are seen with Dapsone therapy. One is primary resistance and the other is secondary resistance. Primary resistance means before the starting of the therapy event, the person is resistant to Dapsone. That is primary resistance, and it occurs because of patient harboring resistant bacilli. The patient has contracted the disease from a person that is harboring the resistant bacilli. Number two is secondary resistance. Patient has been put on the Dapsone, and then afterwards the patient develops Dapsone monotherapy, and afterwards the patient has developed resistance. That is secondary resistance, and it occurs because of selective propagation of resistant bacilli, like that in case of Mycobacterium tuberculosis. Now, how the resistance develop? Because of mutation in the folate synthase enzyme. There is also a term called persisters, where the drug sensitive bacilli, the drug is sensitive to Dapsone, but it has become dormant and it has been basically hidden in some tissues. So, they are not affected by the drug, and when the drug is withdrawn, the symptoms again reappears. So these are called persisters. Pharmacokinetics, they are absorbed after oral administration, widely distributed, particularly in the lepromatous skin. So they are very helpful in the skin lesion. So they are widely distributed, concentrated in skin, especially lepromatous skin. They are concentrated in muscle, liver and kidney. Now the drug is cumulative. Basically they show enterohepatic circulation, and the drug is cumulative due to retention in tissues and enterohepatic circulation. The T-half or the elimination basically occurs in 1 to 2 weeks. Dapsone is generally well tolerated. Mild hemolytic anemia can be seen, particularly they are common in G6PD deficient patient, and even a lower dose 50 mg per day can induce hemolysis in such patients. Gastric intolerance can be seen like nausea and anorexia, but as the drug is continued, those symptoms can be overcome. And other side effects are methemoglobinemia, headache, paresthesia, mental symptoms and drug fever. Cutaneous reactions can be seen like anaphylactic reactions, allergic rashes, fixed drug eruptions, hypermelanosis and others. Hepatitis and agranulocytosis are rare but serious complication, and there is a term called sulfone syndrome that occurs after the institution of Dapsone therapy, seen after around 4 to 6 weeks of therapy. It consists of fever, constitutional symptoms, body ache, lymph node enlargement, the desquamated skin can be there, jaundice and anemia. They are particularly seen in malnourished individuals who are treated with Dapsone, number one, and it has been now frequently seen because of institution of multi-drug therapy. And it can be treated by stopping the Dapsone therapy till the disease subsides and institution of corticosteroid therapy, prednisolone. It is contraindicated in severe anemia, hemoglobin less than 7 because of the risk of hemolytic anemia. It is contraindicated in G6PD deficiency and in patient showing hypersensitivity reaction. Other use of Dapsone other than leprosy. It is one in chloroquine resistant malaria. It is used with pyrimethamine. So Dapsone is can be combined with pyrimethamine for the treatment of chloroquine resistant malaria, number 1, number 2 toxoplasmosis, and number 3 pneumocystis jirovecii pneumonia. So these are the use of Dapsone therapy in conditions other than leprosy. Now coming to the second drug, Clofazimine. Clofazimine is basically a dye that is showing leprostatic and anti-inflammatory property. Mechanism of actions are, number 1, interference with template function of DNA, alteration of membrane structure and transport function, and disruption of the mitochondrial electron transport chain. Now, when used alone, Clofazimine is slow to act compared to Rifampicin, but it shows efficacy even in Dapsone resistant individual. Dapsone resistant M. leprae respond to Clofazimine, but apparently after a lag period of 2 months. When a patient is put on Clofazimine monotherapy, basically resistance can develop in 1 to 3 years. It is orally absorbed and basically they accumulate in macrophages, get deposited in many tissues including subcutaneous tissue as crystals. As needle-shaped crystals, their entry in CSF is poor. Half-life is around 70 days. So intermittent therapy is possible with Clofazimine. Clofazimine is used as multi-drug therapy in leprosy. What are the other use? In Lepra reaction, we will come to it later on, and as multi-drug therapy for Mycobacterium avium complex infection. So Clofazimine used other than leprosy are, number 1, Lepra reaction, and number 2 as multi-drug therapy for Mycobacterium avium complex. Adverse effects generally well tolerated. As dye, it causes reddish black discoloration of skin. They also discolor the hair and the body secretion, dryness of skin and itching can be seen, conjunctival pigmentation can be seen. Nausea, anorexia, abdominal pain, weight loss, enteritis with intermittent loose stool can occur. Now, gastrointestinal symptoms seen with the use of the clofazimine. Basically, they can be of two types, early and late presentation. Early presentation is due to the irritant effect of the drug that can be managed with adjustment of dose and taking the drug after meal. And the other one is late gastrointestinal symptom that occurs due to the deposition of the clofazimine crystals in the intestinal submucosa. Clofazimine is to be avoided in early pregnancy and in patient with liver or kidney damage. Coming to the rifampicin. Rifampicin is the basically leprocidal drug. It is the most potent cidal drug. It rapidly renders leprotic patient non-contagious within few days. Up to 99.99% of M. leprae are killed in 3 to 7 days by a dose of 600 mg per day. Clinical effects of rifampicin are very rapid. Nasal symptoms, they go away by 2 to 3 weeks. The skin lesion start to disappear by 2 months. Nerve damage already incurred with the progression of disease is little affected by the use of rifampicin. Moreover, it is not satisfactory if it is used alone because of the risk of emergence of resistance. Now, they have been included as a part of multi-drug therapy of leprosy because of shortening the duration of the therapy and because of inhibiting the development of resistance to the drug. Persistence of dormant rifampicin sensitive bacilli can be seen even after the completion of multi-drug therapy. In those cases, after the drug is withdrawn, there is a chance of relapse that can be treated with the same multi-drug therapy regimen. Okay. Rifampicin remains effective in leprosy even if given once a month. So, rifampicin in patients of leprosy are given once a month, 600 mg per month. The 600 mg monthly dose used in multi-drug therapy is practically non-toxic, does not cause enzyme induction. So, this is the advantage of taking monthly dose. They are non-toxic and enzyme induction is not seen with such dose. It should not be given in a patient of hepatic or renal dysfunction, in patient of Lepra reaction, in patient with reversal reaction. এই দুটো term Lepra reaction, reversal reaction আমরা পরে পড়ব. Why they are not used in such patients in Lepra and reversal reaction? Because as it is cidal drug, it rapidly kills the Lepra bacilli. So, it basically releases large quantity of mycobacterial antigen and that further accentuates the reaction. Now, coming to the other anti-leprotic drugs, number 1, ofloxacin. Basically, many fluoroquinolones are active against Mycobacterium leprae like ofloxacin, pfloxacin, sparfloxacin, moxifloxacin. Ofloxacin has been largely used for the treatment of Mycobacterium leprosy. Ciprofloxacin has got poor activity against M. leprae, so they are not used. Now, it is cidal to M. leprae. They have not been included in the standard multi-drug therapy of leprosy. They are used as an alternative regimen where rifampicin are resistant or standard therapy cannot be used. Moxifloxacin is the most potent fluoroquinolone against M. leprae. Coming to the minocycline. Minocycline basically is a cidal drug. Its anti-leprotic activity is less marked than rifampicin. They are used as an alternative regimen. Vertigo is the only serious complication when the drug is used for longer duration. Clarithromycin is the only macrolide that shows anti-leprotic activity. It is a leprocidal drug but definitely less bactericidal than rifampicin. Rapid clinical improvement and bacteriological clearance is seen in patients of lepromatous leprosy. synergistic action with minocycline has been noted with the drug. It is being included in alternative multi-drug therapy regimen. Coming to the treatment of leprosy. Now, leprosy is a chronic granulomatous infection caused by Mycobacterium leprae that affects the skin, mucous membrane and the nerves. And basically they are more prevalent in the lower socioeconomic individuals. Now, in India, initially National Leprosy Control Program was launched in 1955. Then, following the footstep of the WHO in 1982, they launched National Leprosy Eradication Program that started the use of multi-drug therapy for leprosy. Now, with the use of multi-drug therapy, they achieved elimination of leprosy as a public health problem. Even after the drastic fall in leprosy prevalence worldwide and in India, 65% of all new leprosy cases worldwide are still noted from India, Brazil and Indonesia. Now, what are the types of leprosy? Leprosy can be tuberculoid leprosy, also called paucibacillary leprosy. Paucibacillary leprosy denoted by PB and tuberculoid leprosy denoted by TT. And the second one is multibacillary leprosy or denoted by MB, or lepromatous leprosy denoted by LL. And the third one is borderline leprosy, where the features of both are there. So, in paucibacillary leprosy, there can be 1 to 5 skin lesions, and in multibacillary leprosy, there the lesions are 6 and above. Peripheral nerve involvement, generally in paucibacillary leprosy, no nerve involvement can be seen or a single nerve involvement can be seen. With skin lesion, with or without skin lesion 1 to 5. In multibacillary leprosy, there is more than one nerve involvement and irrespective of the number of skin lesion. And when we see skin smear, it is negative in case of tuberculoid leprosy or paucibacillary leprosy, well it is positive in case of multibacillary leprosy. So, these are the method of differentiation between tuberculoid leprosy and the lepromatous leprosy. Advantage of multi-drug therapy of leprosy, like that in case of tuberculosis. Number 1, effective in cases with primary Dapsone resistance. Number 2, prevent emergence of Dapsone resistance. Number 3, quick symptomatic improvement and renders the multibacillary leprosy non-contagious within few days. Reduces total duration of therapy and side effects are minimal. Compliance is better. Now, multi-drug therapy of leprosy stand over 3 drugs. These are stand pillars. Number 1, Rifampicin, Clofazimine and Dapsone. Rifampicin is used in a dose of 10 mg per kg body weight monthly once under supervised condition. Clofazimine, it is used in a dose of 6 mg per kg body weight once monthly under supervised condition and 1 mg per kg body weight daily non-supervised. And Dapsone 2 mg per kg body weight daily non-supervised. Now, coming to the multi-drug therapy of leprosy regimen. Now, we treat paucibacillary leprosy with 2 drugs. Number 1 is Rifampicin, number 2 is Dapsone. Rifampicin we give 600 adult dose 600 mg once monthly supervised, and we give Dapsone 100 mg daily non-supervised. The duration of therapy is 6 months. And coming to the multibacillary leprosy, we use 3 drugs. One is Rifampicin 600 mg once monthly supervised, Dapsone 100 mg once monthly unsupervised, and finally Clofazimine we use basically 300 mg once monthly supervised and 50 mg daily non-supervised. Duration of therapy for multibacillary leprosy is 12 months. Okay, these are the standard protocol for the treatment of leprosy under the National Leprosy Eradication Program. Now, many alternative regimens are also available for the treatment of leprosy, particularly where rifampicin resistance is seen or in patient where the standard multi-drug therapy cannot be used. So, number one is intermittent ROM. ROM stands for R for rifampicin, O for ofloxacin, and M for minocycline. We use rifampicin 600 mg, ofloxacin 400 mg, and minocycline 100 mg once monthly, intermittent, once monthly for 3 to 6 months for paucibacillary leprosy and for 12 to 24 months for multibacillary leprosy. Then the second regimen, single dose ROM. So here basically we are using single dose of rifampicin 600 mg, ofloxacin 400 mg, and minocycline 100 mg in a patient with single lesion paucibacillary leprosy. paucibacillary leprosy মানে কি 1 to 5 skin lesion থাকতে পারে। যদি single lesion থাকে, that can be treated with single dose ROM. It was initially used under the program but later on discontinued. So it is not used nowadays. Clofazimine 50 mg plus any 2 of ofloxacin, minocycline, clarithromycin daily for 6 months, followed by clofazimine plus any of the ofloxacin, minocycline for additional 18 months. So these are some of the regimens that can be used, but what you have to remember particularly is standard multi-drug therapy of leprosy. That you have to remember. That can be asked in Viva, in the exam, anywhere. Coming to the Lepra reaction. Lepra reaction is seen in a patient of lepromatous leprosy or multibacillary leprosy treated with the standard multi-drug therapy regimen. It coincides with the institution of chemotherapy. At a patient lepromatous leprosy niye esche, we started the chemotherapy. With the institution of chemotherapy, it can be seen or due to the intercurrent infection. Now, it is basically a Jarvis-Herxheimer type of reaction due to release of antigen from the killed bacilli. And what we see basically here is it is abrupt onset. The existing skin lesion can become enlarged, swollen, lymph node can become swollen, there will be fever, and new lesion can appear, and other body ache and other constitutional symptoms can be seen. Now, in severe or life-threatening form, erythema nodosum leprosum is noted. Now, how we treat the patient? We temporarily discontinue Dapsone in severe cases. Number one, clofazimine can be continued in a dose of 200 mg daily because of its anti-inflammatory property. Clofazimine can be continued in a dose of 200 mg daily in mild to moderate cases, but it should be avoided in severe case. For severe reaction, prednisolone 40 to 60 mg daily to be continued till the symptoms subside and is then gradually tapered off over 2 to 3 months. Thalidomide. Now, thalidomide basically it was introduced in 1950s in the market. It was rampantly used for its anti-emetic property in a patient of early pregnancy for morning sickness. But with the rampant use, it was noted that the babies that were born, it was showing teratogenic potential, phocomelia, and hence the drug was withdrawn. In later part, the drug is again introduced because of its anti-inflammatory and cytotoxic property. This thalidomide drug is used in patients of lepra reaction, in severe lepra reaction, which present with erythema nodosum leprosum. Now, they are also used in other conditions where cytokine storm is seen, and also they are used in multiple myeloma. Other drugs that can be used in lepra reaction that include antipyretics, analgesics, and antibiotics can be used according to the symptom and need. Chloroquine can be used in lepra reaction to suppress it. Now, coming to reversal reaction. Reversal reaction is seen in patients of borderline leprosy and in paucibacillary leprosy. Now, it occurs due to manifestation of delayed hypersensitivity to the M. leprae antigen. Patient presented with paucibacillary leprosy. We started the standard MDT regimen. The therapy is completed. The patient presented with multiple nerve involvement, cutaneous ulceration with swollen, painful and tender nerves even after completion of therapy. So, what the treatment here? Clofazimine can be used or corticosteroid as discussed in Lepra reaction, the same dose. But thalidomide is ineffective in reversal reaction. That's all. এখানে কিন্তু মাল্টি ড্রাগ থেরাপি রেজিমেন্টটা মনে রাখতে হবে, ড্রাগস ইউজ মনে রাখতে হবে, ড্যাপসন আসতে পারে। Now the second topic is chelating agents. Chelating agents are basically the drugs that chelate, that get hold of the metal ions, like the crab holding. The holding is basically feed with two claws. It forms a stable ring-like structure. So these are drugs which complex metallic ions forming ring-like structure within their molecule. The word has come from the Greek word meaning a crab that hold the compound that hold the metal like a crab's claw. They are primarily used for heavy metal poisoning. Okay. Now the complex formed due to the interaction between the chelating agent and the metallic ion, they are stable, non-toxic and easily excreted complexes. Okay. Now what happens in the chelating agents? They have got two or more reactive molecules or ligands. So they have got two or more reactive molecules which can hold the ligand or which can hold the metallic ion from at least two ends, so that a stable ring-like structure is formed. When the ring is 5 to 7 membered, it is most stable. Now, ligand is a functional group capable of forming covalent bond. Now, heavy metal basically they exert their harmful potential by binding to the reactive molecules in the tissues and inactivating the functional groups in the enzyme and other critical biomolecules. Now what does chelating agent do? They compete with the body ligands for the heavy metal. They bind to the metal and forming the stable complex, the complexes are easily excreted. Thus they basically inhibit the toxicity caused by heavy metal. Clinically useful agent should have, what are the criteria for a chelating agent? It should have a higher affinity for the metallic ions than the body tissues, number one, then the body ligands, and it should have a higher affinity for the metallic ions than for calcium. Why? Because calcium is readily available in the bones and the plasma. Their distribution in the body should match with the distribution of the metallic ions in the body, so that they can bind to the metallic ions, and they should be water soluble. Efficacy of all chelating agent in promoting the excretion of the metallic ions and in reversing toxic manifestation declines rapidly as the interval between the entry of the metal in the body and the administration of chelator increases. So how quickly we treat a patient with heavy metal poisoning with the chelator agent is the better result we get. Now what are the chelating agents that are available? Number one is dimercaprol, also called British anti-leprotic, BAL, dimercaptosuccinic acid, also called Succimer, Disodium Edetate, calcium disodium edetate, calcium disodium DTPA, Penicillamine, particularly D-Penicillamine, dextroisomer, Desferrioxamine and Deferiprone. Dimercaprol, also called British anti-leprotic. Here basically we have got two sulfhydryl reactive group. Now it is an oily, pungent smelling, viscous liquid. It was developed in the World War II to antagonize by the Britishers as an antidote to the arsenical war gas Levicide, so called British anti-Levicide. Now, the 2-sulfhydryl group of dimercaprol, they bind with the metals and thus they reduce the toxicity of arsenic, mercury, gold, bismuth, nickel, lead and copper. The complex of two molecules of dimercaprol and with one metal ion is more stable than 1:1, and it is for that reason it is desirable to maintain excess concentration of dimercaprol in the body to allow formation of 2:1 complex. Again, dimercaprol metal complex, they spontaneously dissociate, releasing the metal at a slow rate. Also, dimercaprol is partly oxidized in the body. So for that reason also higher concentration of dimercaprol is needed in the body. But again, it shows, dimercaprol shows dose dependent toxicity. So the larger amount of the drug has to be given at a slower rate, so that lesser dose dependent toxicity can be seen. Now they are used in the poisoning by arsenic, mercury, gold, bismuth, nickel and lead. They are administered intramuscularly. They can be used in lead poisoning as an adjuvant, not a good choice. So as an adjuvant to calcium disodium edetate. Calcium disodium edetate is the drug of choice in lead poisoning. Now they can be used as an adjuvant to penicillamine in copper poisoning and in Wilson's disease. What do you mean by Wilson disease? কি হয় উইলসনে? কি এনজাইম ডেফিসিয়েন্সি থাকে? পড়তে হবে না, এটা প্যাথোলজি। Contraindications. It is contraindicated in iron and cadmium poisoning. Why? Because the dimercaprol complex with the iron and cadmium are toxic. Adverse effect, they are frequent but mild. Not damaging. Rise in BP, tachycardia, vomiting, tingling and burning sensation, inflammation of mucous membrane, sweating, cramps, headache and anxiety can be seen, and that can be treated with the use of antihistaminics prior to the dimercaprol injection. Now coming to the calcium disodium edetate. Calcium disodium edetate is basically a calcium chelate of disodium EDTA. Now they have got higher affinity for lead, zinc, cadmium, manganese, copper and some radioactive metals. They are highly ionized. As they are highly ionized, they show poor absorption oral, so they are used parenterally. Intravenous injections are used because intramuscular are painful, and because they are highly ionized, the distribution is more extracellularly than intracellularly, and basically it is not metabolized. Since IM injection is painful, preferred route is intravenous. It does not enter CSF. Now the most important indication for use of calcium disodium edetate is lead poisoning. So this is the most important indication. These are dose 1 gram is diluted in 200 to 300 milligram at 200 to 300 ml of dextrose or saline and given over 1 hour. It is given for 3 to 5 days twice daily. Then it can be repeated after 5 to 7 days. It is also useful in iron, zinc, copper, manganese and radioactive metal, but they are not used in mercury poisoning. Adverse effect, relatively safe. They show proximal tubular damage that can be managed with large fluid intake. An acute febrile reaction can be seen with chills, body ache, malaise, tiredness. Anaphylactoid reaction can be noted. Penicillamine. Now, penicillamine is a dimethyl cysteine obtained as a degradation product of penicillin. Now, it has got strong copper chelating property. So, they are used in copper poisoning basically. And it selectively chelates copper, mercury, lead and zinc. The dextroisomer of the penicillamine is used therapeutically, not the basically levoisomer or the racemate mixture, because they produce optic neuritis and are more toxic. It is adequately absorbed after oral administration, metabolized little, excreted in urine and feces. Now, Wilson's disease, basically it occurs due to the deficiency of ceruloplasmin. It is an enzyme that is in Wilson's disease, there is genetic defect due to deficiency of ceruloplasmin which bind copper and remove the copper from the body. So, in patient of Wilson's disease, there is deposition of copper in the liver, in the brain. So, which normally binds and disposes of copper from the body. In its absence, plasma concentration of free copper is high. They get deposited in liver, in the substantia nigra and basal ganglia of the brain, and they cause local degeneration. In this type of patients, lifelong therapy with penicillamine has to be given, and potassium sulfide can be added to reduce the absorption of the dietary copper. Now, in copper and mercury poisoning, it is a drug of choice in copper poisoning, and alternative in mercury poisoning where the drug of choice is succimer. Now, it can be used in chronic lead poisoning, in cystinuria and cystine stone, in scleroderma patient where it solubilizes the collagen, and it was initially used as a disease modifying agent in rheumatoid arthritis, but the drug has been withdrawn. Adverse effects: short term administration does not cause much problem. Cutaneous reactions can be seen with itching and febrile episodes. Long term use of D-penicillamine that cause dermatological, renal, hematological and collagen tissue toxicities. Coming to the Desferrioxamine, is a drug of choice in acute iron poisoning. So, ferrioxamine is a long chain iron containing complex. They are obtained from the actinomycete. Now, from ferrioxamine, if we remove the iron, it becomes desferrioxamine, which has got very high affinity for iron. It removes the loosely bind iron in the body. It also removes iron from the hemosiderin ferritin, but it does not remove iron from the hemoglobin, from the cytochrome. Now, it has got lower affinity for calcium. It is used parenterally. Now, it is a drug of choice in the acute iron poisoning. It may be life-saving event. It can be used in a patient of chronic iron overload, particularly seen in patients of thalassemia. Why? Because thalassemia patients require frequent blood transfusion, and due to frequent blood transfusion, there is iron overload state. So, transfusion siderosis occurs in thalassemia patients who receive multiple blood transfusion. Desferrioxamine 0.5 to 1 gram per day IM help to excrete chronic iron overload. Now, the problem with desferrioxamine, they release histamine, and due to histamine release, there can be hypotension, fall in blood pressure, flushing, itching, urticaria, rashes, allergic reactions can be seen. Other side effects are abdominal pain, diarrhea and others. Deferiprone, it is also used in iron poisoning, but the advantage is it is used orally. It is the oral iron chelator, but the efficacy of deferiprone is lesser than desferrioxamine. So, it is an orally active iron chelator. It is particularly used in transfusion siderosis in thalassemia patient. Okay. Now, oral deferiprone is somewhat less effective than desferrioxamine. Side effects and cost of treatment are lower compared to desferrioxamine. Deferiprone has been indicated for acute iron poisoning and for iron overload state even in liver cirrhosis. Side effects are anorexia, vomiting, altered taste, joint pain, reversible neutropenia and rarely a granulocytosis. However, long-term safety is not known. That's all.